Hello, my name is Quentin Broussard. I'm Assistant Professor of Clinical Sciences at California Health Sciences University, and today we will be discussing hypertensive crisis. And the reason that we're discussing this topic today is that hypertension affects millions of people in America as well as worldwide. As a pharmacist, it's important to recognize hypertensive crisis whenever it presents to you, as well as the pharmacotherapy related to hypertensive crisis, in order to treat hypertensive crisis appropriately. And that includes mechanism of action of medications, as well as adverse effects and special considerations regarding each of the medications used in hypertensive crisis. Our objectives for today will be to distinguish hypertensive urgency from hypertensive emergency, determine blood pressure and mean arterial pressure goals for hypertensive emergency, review medications used for hypertensive crisis, and identify appropriate pharmacotherapy for hypertensive crisis based on disease state. We'll start off with a case. PB is a 63-year-old male presenting to the ED with altered mental status, vomiting, and numbness of his left side. Vitals upon admission include blood pressure 195/98, heart rate 121, respiratory rate 24, and oxygen saturation 94%. A CT scan was completed briefly after arrival to the ED and revealed an intracerebral hemorrhage. PB has no significant past medical history and was not taking any medications prior to admission. Which of the following best describes PB's current blood pressure? Is it normal tension, hypertension, hypertensive urgency, or hypertensive emergency? The next question, which of the following is the best option to initiate to manage PB's blood pressure? Is it Clonidine PO times 1, Fenoldopam IV continuous infusion, Nicardipine IV continuous infusion, or is PB's blood pressure not requiring intervention? The last question is, what is the maximum percentage that mean arterial pressure, or MAP, should be decreased by over the first hour of treatment for PB? Is it 15%, 25%, 50%, or 75%? After we discuss hypertensive crisis today, you should be able to answer each of these questions confidently. In terms of epidemiology of hypertension as well as hypertensive crisis, as we mentioned before, hypertension affects millions of Americans and over 1 billion people worldwide. And these were statistics from a paper from 2009, so these numbers are likely to be even more now. Per GNC 7 guidelines published back in 2003, up to 60% of adults ages 18 and older have prehypertension or hypertension, making hypertension one of the most prevalent disease states in the world. Severe hypertensive episodes comprise about or up to 25% of urban emergency room visits. So as a result of this, a lot of traction is seen with patients presenting with hypertension to emergency rooms. And as a result of this contributes to morbidity as well as mortality in addition to cost. In terms of what hypertensive crisis actually is, hypertensive crisis can be broken down into two subsets: hypertensive urgency and hypertensive emergency. With either which one, the definition is a severe elevation of blood pressure with a systolic blood pressure greater than 180 and or a diastolic greater than 120. So you can have either of these criteria, systolic greater than 180 or a diastolic greater than 120, or both of these criteria in order to meet criteria for hypertensive crisis. Now, what the difference is between hypertensive urgency and hypertensive emergency is that with hypertensive urgency, you don't have any progressive target organ damage, versus with hypertensive emergency, you do have progressive target organ damage. So emergency, you have organ damage. With urgency, you don't. And with both, you have systolic greater than 180 and or diastolic greater than 120. So you may be asking, what exactly is the definition of target organ damage? Well, according to the JNC 7 guidelines back in 2003, target organ damage can be defined as encephalopathy or altered mental status, intracerebral hemorrhage, which is essentially a type of brain bleed, acute myocardial infarction or heart attack, acute left ventricular failure with pulmonary edema, which you would commonly see with a CHF exacerbation, for example, renal insufficiency, so essentially acute kidney injury or AKI, unstable angina or unstable chest pain, a dissecting aortic aneurysm, or essentially an aneurysm or dilatation of the aorta to where that aorta actually breaks off and dissects, resulting in the creation of a true and a false lumen, which may be fatal. Another example of target organ damage is eclampsia, or essentially seizures related to a pregnancy. In terms of the etiology of hypertensive crisis in general, so hypertensive crisis encompasses hypertensive urgency as well as hypertensive emergency. There are many different things that can cause a hypertensive crisis as well as hypertension. One of the big things is non-compliance with medications. So say if a patient has a diagnosis of hypertension previously and they're not compliant with their medications, they may eventually go into a hypertensive crisis. If the patient is not adequately diagnosed, or if they're not being adequately treated for their hypertension, so if their medications are not being titrated appropriately, or if they're not going to their doctor's appointments to have their medications titrated appropriately, that can also be an issue. Diet is one of the non-pharmacological things that we also worry about, though in terms of diet can also be a little bit pharmacological, as diet may involve alcohol, licorice, not necessarily Twizzlers, but the herb, as well as sodium content of different foods. The more of each of these factors that plays a role in a patient's diet, the higher the risk of hypertension, as well as the higher the risk that they may develop a hypertensive crisis. Certain disease states may play a role in the development of hypertensive crisis. Some examples of disease states that may cause a hypertensive crisis include chronic kidney disease, Cushing's disease, as well as pheochromocytoma, which is a type of catecholamine-secreting tumor which can eventually lead to hypertension and hypertensive crisis. Another factor that's important to consider when evaluating hypertensive crisis is patients' medications, and that can include prescription drugs as well as illicit drugs. Some prescription drugs that may contribute to hypertensive crisis include amphetamines such as dextroamphetamine, methylphenidate, phentermine, etc. And a lot of these agents are actually used for the treatment of ADHD, which you'll learn about in Patient Care 3. Other agents may include decongestants, such as pseudoephedrine or phenylephrine. If a patient has hypertension, they should probably not be using a decongestant, as it may exacerbate their hypertension. NSAIDs may also be related to hypertension and hypertensive crisis as a result of damage to the kidney, as well as fluid retention. Estrogen-containing contraceptives may contribute to hypertension and hypertensive crisis, particularly those with estradiol. Nicotine and nicotine withdrawal can also contribute to hypertension and hypertensive crisis. In terms of illicit drugs, one of the most popular presentations of hypertensive crisis with an illicit drug is cocaine and cocaine withdrawal. Some other presentations include ephedra alkaloids, i.e. mahuang. in general, for goals of therapy of a hypertensive crisis, it's important to reduce blood pressure in a controlled and predictable manner. So we don't want to necessarily, overcorrect blood pressure too quickly, but we want to make sure that we do correct the blood pressure to minimize any further organ damage that may occur. We want to weigh the pros and cons of selected pharmacotherapy, particularly with consideration of adverse effects, because some patients may have the adverse effect of the medication you select already. In addition, we want to consider other patient-specific factors when selecting an agent, and this can include patient's race, age, pregnancy status, volume status, and other comorbidities. With age might be a concern because some of these agents may actually cause drowsiness or may be on the Beers criteria and have concerns related to age-specific pharmacokinetics and pharmacodynamics. Certain differences between patients' race may also play a factor. One of the examples we'll talk about is with Enalaprilat. Pregnancy status is also important in regards to treating hypertensive crisis, as a lot of medications that we have available are actually contraindicated in pregnancy. In terms of volume status, some of these medications that we'll talk about actually carry a pretty hefty volume load associated with them because they're IV continuous infusion. And we also have to consider other comorbidities that a patient has as a result of a lot of medications having contraindications in certain disease states. When approaching a patient that has a hypertensive crisis, you have different treatment paths that you may take depending on whether or not you have hypertensive urgency or hypertensive emergency. In regards to hypertensive urgency can be treated outpatient or in an emergency department and only requires oral or short-acting antihypertensive agent administration. Patients may benefit even from an adjustment of their current oral antihypertensive regimen, and this can include use of combination medications. One that I like to think of that's pretty common is an ACE inhibitor plus a thiazide diuretic. A titration of medications. Maybe the patient may have not been at their optimal dose of medication to manage their hypertension, and as a result needs to have a dose increase. Or maybe they may need to restart certain medications if they are not compliant with their medications. And one of the most common presentations is with Clonidine. Patients who discontinue Clonidine will have a rebound hypertension that occurs, which can be very concerning and stimulate essentially a hypertensive crisis. So starting that agent again, which is essentially the source of the problem, may help relieve the hypertensive crisis. In comparison, hypertensive emergency is managed a bit differently than hypertensive urgency. With patients with hypertensive emergency, they should come to the hospital and be admitted to the intensive care unit for continuous blood pressure monitoring, and this can be done with an A-line. With hypertensive emergency, considering the fact that they have some type of organ damage that has already happened, parenteral medications, so IV medications, are usually warranted in the treatment of hypertensive emergency. When talking about hypertensive emergency and the blood pressure and MAP goals for that specific indication, it's important that mean arterial pressure is reduced by no more than 25% in the first hour to minimize complications as well as further organ damage. And some of the other complications that may occur are hypotension, for example, bradycardia. Acute kidney injury may be exacerbated as a result of lowering mean arterial pressure too much, as well as lessening of cerebral perfusion if blood pressure is lowered too quickly. After the first hour, if the patient is stable, then a blood pressure goal of 160 to over 100 to 110 millimeters of mercury should be targeted within the next 2 to 6 hours. So essentially what we're doing is we're doing a slow titration to an eventual blood pressure goal. And then you may want to see a gradual reduction to blood pressure goal within 24 hours, and that can even go more commonly to 48 hours. So anywhere between 24 to 48 hours is probably reasonable for a blood pressure reduction goal. Some exceptions to the rules of blood pressure goals and MAP goals for hypertensive emergency include ischemic stroke, because with patients with ischemic stroke will actually want to keep their blood pressure a little bit higher to maintain cerebral perfusion. Patients who also have thrombolytic administration, such as alteplase, will have their own specific requirements regarding blood pressure, as they will need to be kept under a certain blood pressure amount to minimize the risk of bleeding as a result of thrombolytic administration. Another exception is a patient that may have aortic dissection. And in those patients, we actually want to target a systolic blood pressure less than 100 if they can tolerate it, to minimize the pressure that is essentially being placed within the aorta that can eventually lead to massive amounts of blood leaving the aorta and third spacing, essentially. And this can eventually cause a mortality. So, in terms of medications that are available for hypertensive crisis, we're going to divide them up into oral medications and intravenous medications. Oral medications that are available for the treatment of hypertensive urgency specifically. Remember, hypertensive urgency does not have any organ failure related to it. These medications include Captopril, Labetalol, and Clonidine. The first agent we'll talk about is Captopril. As you guessed from its suffix, Captopril is an angiotensin-converting enzyme inhibitor, an ACE inhibitor. And traditionally, in hypertensive urgency, the dosing is 25 milligrams PO or sublingual, and you can repeat this dose as needed. Traditionally, this medication can be dosed every 8 hours. Its onset of action is within 15 minutes, and its duration of action is actually dose-related. There's no specific time frame in terms of its duration of action. If you don't have any response in blood pressure within 20 to 30 minutes, you may want to consider an alternative agent to Captopril after initial administration. Some adverse effects of Captopril include flushing or syncope, orthostasis, angioedema, which is one of the big hallmarks of the ACE inhibitor class, as well as rash, in addition to renal insufficiency. Labetalol is a dual alpha-1 and beta-1 and beta-2 antagonist. So it actually antagonizes 3 different catecholamine receptors. In regards to its dosing by mouth, and I mentioned by mouth specifically because Labetalol also has an intravenous formulation that we'll talk about a little later. Its dosing is traditionally between 100 to 300 milligrams by mouth for a dose, with traditional maintenance dosing maximizing at 2,400 milligrams per day. Its onset of action is between 20 minutes to 2 hours, and its duration of action is between 8 and 12 hours. It is contraindicated in COPD, and this is probably most likely to its effects on beta-2, or its lack of effects on beta-2. In addition to second and third degree atrioventricular block, as well as bradycardia, which is a hallmark adverse effect of the beta blocker class. Its adverse effects include bradycardia, orthostasis, dizziness, as well as fatigue. In regards to clonidine, clonidine is an alpha-2 agonist that acts centrally. Its dosing traditionally for hypertensive urgency is anywhere between 0.1 to 0.2 milligrams PO, and this dose can be repeated hourly to a maximum of 0.7 milligrams. Its onset of action is relatively quick, within 30 minutes to an hour, and its duration of action is between 6 to 10 hours, which is why you see clonidine maintenance regimens typically dosed every 8 hours. An important point with clonidine is that when you withdraw clonidine from a patient who's been on clonidine for a while, they may actually have a rebound hypertension as a result. Clonidine is a very strong antihypertensive agent and is a go-to for a lot of different clinicians. So if you notice that your patient has some kind of history of clonidine usage, this may actually be the agent to start. In regards to adverse effects of clonidine include drowsiness, which is one of the reasons why clonidine should be used cautiously in elderly patients. Headache, fatigue, dizziness, abdominal pain, and it may cause some bradycardia as well, though the bradycardia is probably not as high in incidence compared to beta blockers. Now that we've talked about the PO medications used for hypertensive urgency, now we will talk about the intravenous medications or IV medications used for hypertensive emergency. So remember, hypertensive emergency is when we have some kind of target organ damage. And there are many medications that are available for hypertensive emergency. These include Enalaprilat, Hydralazine, Phentolamine, Labetalol, Esmolol, Nicardipine, Clevidipine, Fenoldopam, and then a few common medications that you actually saw in regards to acute decompensated heart failure, which are Nitroglycerin, Nesiritide, and Nitroprusside. Nitroglycerin and Nitroprusside actually being more common than Nesiritide. The first agent we'll talk about is Enalaprilat, and based off of its base word, as you guessed again, it is an ACE inhibitor. And this is actually an active metabolite of enalapril. Traditional dosing of Enalaprilat is between 1.25 to 5 milligrams IV every 6 hours. It has an onset of action of 15 minutes and a duration of action between 6 to 12 hours, which is why it's traditionally dosed every 6 hours. One note with Enalaprilat is that it may not work in patient populations that have low renin levels, because remember, whenever you work to inhibit the ACE enzyme, you're essentially inhibiting renin levels as a result of inhibiting RAS. And this does not play very well in the African American population because they actually traditionally have low renin levels. So it may not be the best agent to use in an African American patient. Similar to what we talked about with Captopril, it actually has some similar side effects, including angioedema and rash, which is pretty hallmark for the ACE inhibitor class, in addition to dizziness and headache. Hydralazine is a peripheral arterial vasodilator, so it only works on the arterial beds to vasodilate. It is an intermittent dose of 10 to 20 milligrams IV every 4 to 6 hours. It has an onset of action of 10 to 30 minutes and a duration of action of 1 to 4 hours. It's important that you watch hydralazine use in patients that have lupus, as this may actually exacerbate lupus and cause lupus-like episodes. An important note is that hydralazine is contraindicated in coronary artery disease. Some adverse effects of hydralazine include reflex tachycardia, and this commonly occurs upon discontinuation of hydralazine, flushing, headache, vomiting, and aggravation of angina. The next agent we'll talk about is phentolamine. This is a peripheral alpha-1 and alpha-2 antagonist. It's dosed intermittently as well as a continuous infusion, though the intermittent dose is probably more common. The dosing for the intermittent dosing is 1 to 15 milligrams IV bolus. The continuous infusion dosing is 1 to 40 milligrams per hour. It has an onset of action of 1 to 2 minutes and a duration of action of 10 to 30 minutes. It's traditionally used most commonly in states of catecholamine excess, and this includes pheochromocytoma, which is that catecholamine secreting tumor. It is also used in regards to patients who have MAOI drug interactions with specific foods, such as tyramine-containing foods. It's also used in regards to patients who overdose with cocaine as well as amphetamines. And it's also used for extravasation of vasopressors, specifically those that work on the alpha beds like norepinephrine. It is contraindicated in patients who have history of MI or coronary artery disease, and its adverse effects include tachycardia, flushing, and headache. The next agent we'll discuss is labetalol. Labetalol is a dual alpha, and this is alpha-1 specifically, and beta-1 and beta-2 antagonists, as we discussed earlier with the PO labetalol. However, I did want to include a slide for labetalol in regards to its IV considerations. In regards to the dosing of labetalol, labetalol is traditionally dosed between 20 to 80 milligrams IV bolus every 10 minutes and 1 to 2 milligrams per hour for its continuous infusion. Its onset of action is between 2 to 5 minutes, and its duration of action is approximately 2 to 18 hours. As we mentioned before, it's contraindicated in COPD, second and third degree AV block, and bradycardia, because, again, it's a beta blocker. Its hallmark is bradycardia for the beta blocker class. So, again, adverse effects are bradycardia, orthostasis, dizziness, and fatigue. The next agent we'll talk about is Esmolol. This agent, unlike labetalol, is specific for the beta-1 receptor as an antagonist. And its dosing includes a loading dose of 0.5 to 1 milligram per kilo IV and a continuous infusion of 50 to 300 mics per kilo per minute IV continuous infusion. It has a short onset of action between 1 to 2 minutes and a duration of action between 10 to 30 minutes. Esmolol traditionally uses the drug of choice in patients who have an acute aortic dissection associated with hypertension. And what this agent does, as well as other beta blockers, is that it actually reduces the dilatation rate associated with the aorta. So it actually tries to narrow the aorta down so that the aorta will not bleed out as much, essentially, in regards to an aortic dissection. The IV formulation, to note, is very dilute and may actually cause volume overload, especially when patients are receiving high IV continuous infusion doses of this medication. For example, in the example actually shown on your right with this 2,500 milligram in 250 bag, say if you had a 100 kilogram patient present with an acute aortic dissection and you needed to titrate them all the way up to 300 mics per kilo per minute of Esmolol, that would actually result in about a 3 milligram administration. Actually, a 30 milligram administration per minute. Therefore, if you had a patient receiving this max dose of Esmolol that we have here, this bag would not last any longer than 100 minutes. And if you need this medication continuously, that results in multiple bags being used per day, and eventually a lot of volume being used per day, because each of these bags is 250 mils. So that's important to note. It's contraindicated in acute decompensated heart failure as well as bradycardia, as it is a beta blocker. And its adverse effects include bradycardia, nausea, and first-degree heart block. The next agents we'll talk about are actually calcium channel blockers, Nicardipine and Clevidipine. Nicardipine is a dihydropyridine calcium channel blocker, so it's essentially similar to the amlodipines and nifedipines of the world. Its dosing is between 5 to 15 milligrams per hour IV continuous infusion, and its onset of action is between 5 to 15 minutes. It has a duration of action of less than or equal to 8 hours. An important part to note about Nicardipine is that steady state-wise, its steady state's achieved after 24 to 48 hours of continuous infusion. And this is important to note because you may not see the full effect of Nicardipine immediately. You may see about 50% of the effect of Nicardipine over the first 45 minutes to an hour of administration, but the full effect is not seen until about a day or two of total administration. Some adverse effects of Nicardipine include headache, flushing, dizziness, nausea and vomiting, and then pedal edema, as it is a dihydropyridine calcium channel blocker. Similar to Nicardipine, Clevidipine is also a dihydropyridine calcium channel blocker. Its dosing is between 1 to 32 milligrams per hour IV continuous infusion. It has a short onset between 2 to 4 minutes and a duration of action between 5 and 15 minutes. An important thing to note about Clevidipine is, unlike all of the other antihypertensive IV agents that we're talking about, this agent is actually formulated as a lipid emulsion, and as a result can actually contribute to the amount of calories that you receive per day in regards to a patient's nutritional status. Because it is made out of lipid emulsion, and the lipid emulsion contains egg as well as soy and soybean, it is contraindicated in patients who have some kind of egg, soy, or soybean allergy. Some important points to note about Clevidipine is that it can cause atrial fibrillation, nausea, vomiting, fever. In addition, it actually may result in acute renal failure and acute respiratory failure in certain patients. And another note is that, in difference to Nicardipine, Clevidipine has to be extensively titrated due to its shorter duration of action versus Nicardipine, which may have a longer duration of action. So that's actually one reason why Clevidipine doesn't actually get used as much as Nicardipine, but it still is an agent that we can potentially use for hypertensive emergency. Fenoldopam is also an agent that you don't see very much in the hospital setting, at least from my experience. It's a peripheral dopamine type 1 or D1 agonist, and it acts as a vasodilator of peripheral arteries as well as renal and mesenteric vasculature. It has a dosing of 0.1 to 1.6 mg per kilo per minute IV continuous infusion. It has a short onset of action and a duration of action about 1 hour. In regards to unique things about Fenoldopam, its use should be cautioned with patients who have glaucoma, as this agent can increase intraocular pressure, which is important to note. In addition, its adverse effects include tachycardia, headache, nausea, and flushing. Now going on to some agents that we're already familiar with from acute decompensated heart failure. So we've talked about nitroglycerin before. It's converted to nitric oxide in the body. It's primarily a venous dilator, though it may produce some arterial vasodilation at higher doses. We said that the dosing is traditionally between 5 to 200 mics per minute IV continuous infusion, and that you titrate it to effect, which in this case, the effect would be a blood pressure lowering effect. Its onset of action is immediately, and its duration of action is between 3 to 5 minutes. Its adverse effects include, obviously, hypotension, bradycardia, headache, as well as reflex tachycardia, and this occurs commonly upon discontinuation of nitroglycerin. Nesiritide is another agent that we talked about. It's recombinant B-type natriuretic peptide, which we see here on the right. It acts as an arterial, venous, and coronary vasodilator with dosing as 2 mics per kilo bolus, then 0.01 mics per kilo per minute IV continuous infusion, and it should be titrated to effect. Its onset of action is about 15 minutes with a duration of action greater than an hour and potentially up to several hours. Its adverse effects also include hypotension, unique to it being its increase in serum creatinine potentially as an adverse effect, headache, nausea, and abdominal pain, as well as dizziness. And the last intravenous agent that we'll discuss is Nitroprusside, which we've already discussed with ADHF. It acts as a nitric oxide donor and an arterial and venous vasodilator. It's dosed as a continuous infusion between 5 to 300 mics per minute, and it's titrated to effect with a maximum dose of 2 mics per kilo per minute. So again, watch your patient's weight, because that might actually dictate your maximum dose. Its onset of action is less than 2 minutes with a duration of action between 1 to 10 minutes. In regards to its adverse effects include hypotension, as it is an antihypertensive agent. A unique side effect regarding nitroprusside is cyanide and thiocyanate toxicity, which can result in a metabolic acidosis. EKG changes, as well as methemoglobinemia, which we mentioned was rare but may occur as a result of conversion of hemoglobin to methemoglobin, which does not carry oxygen as well as hemoglobin. And these patients will present in acute respiratory distress. The treatment for methemoglobinemia, first line, is methylene blue. So now that we have all of these different IV agents for hypertensive emergencies, how do we essentially determine which one to use in which patient? The most common way to determine that is to see what data each of these agents has behind it and in what comorbidity. So this article from 2009 actually produced a table based off of the evidence that was available for each of these agents and each of these comorbidities. So this will be an important table for you to use in regards to figuring out when to use each of the different intravenous agents for hypertensive emergency. In regards to acute aortic dissection, we said that Esmolol was the first line choice for that. We discussed with ADHF, or acute decompensated heart failure, that the preferred agents would be Nesiritide, nitroglycerin, and nitroprusside. And that kind of goes along with the diagnosis of acute pulmonary edema, being Nesiritide, nitroglycerin, and nitroprusside. In regards to patients who have strokes, particularly acute ischemic stroke and acute intracerebral hemorrhage, the preferred agents for those are Labetalol as well as Nicardipine. In regards to patients who have acute MI, there are many different things that you can use, one of the most common being nitroglycerin, but you can also use Clevidipine, Nicardipine, in addition to Esmolol and Labetalol. So essentially a dihydropyridine calcium channel blocker in addition to a beta blocker or nitroglycerin for this one. In regards to acute renal failure, the data suggests Clevidipine, Fenoldopam, and Nicardipine being decent for this indication. In pregnant patients with eclampsia or preeclampsia, Hydralazine, Labetalol, and Nicardipine can be used. In regards to perioperative hypertension, one of the most common agents that's used is actually Esmolol, though you can get away with a calcium channel blocker or a vasodilator such as nitroglycerin or nitroprusside. And in terms of sympathetic crisis or catecholamine toxicity, we discussed that Phentolamine was a good agent in regards to catecholamine toxicity such as pheochromocytoma. But you can also use Clevidipine, Nicardipine, so essentially your dihydropyridine calcium channel blockers in addition to Fenoldopam. Now, it's important to note that for each of these different indications, these agents are not necessarily listed in regards to which one should be used first line. They're only listed alphabetically. So it's important to also look at the footnotes regarding each of these agents. Here are the references for today's talk. And now we'll go back to our initial patient case. So we have PB, a 63-year-old male, presenting to the ED with altered mental status, vomiting, and numbness of his left side. He came in hypertensive with a BP of 95/98, heart rate of 121, respiratory rate of 24, and an oxygen saturation of 94%. CT scan done revealed an intracerebral hemorrhage. He has no past medical history and was not taking any medications prior to admission. Which of the following best describes PB's current blood pressure? The answer to this question is hypertensive emergency. And the reason that this answer is correct is that the patient's BP is greater than 180 systolic blood pressure. And though we didn't meet the diastolic blood pressure, remember that we only need one to meet definition for a hypertensive crisis. Now at this point, we have to determine whether or not the patient has hypertensive urgency or hypertensive emergency. So remember, with hypertensive urgency, you won't see a lot of symptomatology or any end organ damage related to that. However, we do have that in this patient because this patient actually has altered mental status as well as intracerebral hemorrhage, which are two of the target organ damage criteria that you can use to diagnose a hypertensive emergency. So therefore, hypertensive urgency is not correct in this patient. The next question is, which of the following is the best option to initiate to manage PB's blood pressure? And the answer to this question is Nicardipine IV continuous infusion. So remember, we mentioned that patients who have a hypertensive emergency need some kind of IV medication, whether that be intermittent dosing or intermittent IV bolus or IV continuous infusion. And it can be done either which way. Clonidine PO times 1 would not be appropriate for this patient, as this patient has a hypertensive emergency. If the patient had a hypertensive urgency with no target organ damage, Clonidine PO times 1 might be an option. PB's blood pressure does require intervention because it is hypertensive emergency, therefore the last answer is not correct. And in regards to choosing Nicardipine over Fenoldopam, if we go back to this slide looking at the different indications that we have, this patient has an acute intracerebral hemorrhage. And as a result, the preferred agents for intracerebral hemorrhage are Labetalol as well as Nicardipine. That is why Nicardipine is the correct answer for this question. And the last question, what is the maximum percentage that mean arterial pressure or MAP should be decreased by over the first hour of treatment for PB? The answer to this question is 25%. So remember, we don't want to do it too quickly, but we also don't want to do it too slow. So 15% is actually not correct in this case. And 50% and 75% can actually instigate potential Further acute organ damage, as well as other damage, may occur if your blood pressure is lowered too quickly or even too much, because this can actually result in hypotension. If you have any questions, please feel free to email me. Have a great night.